Hello, I'm Jean Pete, and I welcome you back to our show, Better Living. Better Living is brought to you by the Homestead Hope Foundation and is sponsored by Homestead Hospice, where commitment to education and premier hospice care helps patients and families through life's most important journey. Thank you for joining me again today. We have an important topic to share with you, and we are privileged to host Dr. Nathan Andrew Shapira. Dr. Shapira is a PhD in neuropathology and a medical doctor in psychiatry. And he is with us from Carmen Research right here in Smyrna, Georgia. And we're going to talk about some of the clinical trials he's involved in, what Carmen Research does. We're going to talk about warning signs for some psychiatric diagnoses and Alzheimer's as well. Is that right, Dr. Shapira?
Jean, yes. Thank you very much.
You're welcome. So first of all, why don't we get a little background on you? Who are you and how did you get involved with Carmen Research, and how did you decide this was your passion?
Yes. So I had done a training, as you mentioned. I did work in neuropathology, actually studying things like Alzheimer's and Huntington's disease in various models. And then went on to do a medical degree and focus in psychiatry. I was on faculty at the University of Florida for a number of years, and then worked at a couple of pharmaceutical companies helping to develop new medications in kind of the neurosciences. And then have been at Carmen Research since 2008. And our goal is really to take novel ideas, things that, inventions, if you will, and try to turn them into treatments. It's interesting to think back even to one of the most significant advancements in the last 100 years, which was penicillin and some of the other antibiotics. And penicillin was actually, the aha moment was in the 20s. But the actual getting approval and getting it to people took actually World War II and a lot of exposure to people where they were injured and they were able to try it and see that it really helped heal wounds and things like that. So we're involved in taking potential new medications, testing them in people to make sure they're safe and effective, and then ultimately, hopefully, to market.
And the medications you're involved in is not antibiotics. It's more geared towards psychiatry.
Right. So we've been involved in about 400 studies over the last 34 years. So we're Atlanta's longest running program for developing medications like this and doing clinical research. And we've brought about 40 medications to market in various regions. For example, all three of the Alzheimer's drugs, we were involved in those studies that helped bring those to market. And as well, most of the antidepressants, mood stabilizers. We've been involved in some various pain studies, insomnia, anxiety disorders, and the like.
So let's talk about some of these drugs that you brought to market. You mentioned 3 for Alzheimer's. What are those drugs?
Right. So currently the medications that are on the market, like Aricept and things of that nature.
And Namenda.
Okay. As an example. So what happens is companies will have a compound, like a pharmaceutical company, and they'll take it through animal studies and early human studies, and then they'll look for various sites that have a lot of experience in testing those in humans. And we are often one of those sites, and the company will pick a number of sites around the country or even the world to make sure that an effect in the United States is similar to effect of someone else in another country. And that data is compiled and then presented to the FDA for review and potential approval of that medication to market.
So that brings up some curiosity in my brain. Do you often see that people in the United States might react differently than people in other countries to the meds, or typically people throughout the world react similarly?
There are differences. Some of those are genetic. Some of them are cultural. as well. I mean, one example is there's research showing that Native American and African Americans tend to stop taking treatment at the point they feel better, like an antibiotic, for example, something like that, and that can lead to problems in terms of taking a full course or really having a resolution of a condition, for example. So I mean, they're both cultural changes you see in different cultures, and also genetic. People metabolize things at different rates, or their receptors don't bind the compounds as strongly. So it's important to get a broad range of people, men and women. You also see differences, and sometimes there'll be different recommended doses for women.
Yeah, let's talk about that, because I feel like, as a woman, you read things, true or not, it depends on what you're exposed to, and it may be skewed, but it seems as though more treatments geared towards women are not as available as the treatments that are geared towards men. Is that right or wrong?
I think historically that has been the case. Even some of the way a medication is developed is that first there are animal studies or test tube studies, if you will, of a compound, how it binds, and then it moves into humans. And these aren't per se studies we're involved in, but they're called phase 1 studies, and those are often young individuals who are basically testing how they tolerate a compound, how it's metabolized. So this isn't in the condition they think it'll help in. And those have tended historically to be more young men. So the first testing of a compound has often been, in how it's metabolized and how it's tolerated. I think there's some change in that, and there's certainly a push to include women earlier in these kind of studies, or in early development studies, so that there is a better understanding of.
Well, that's good news.
Yeah, I think there's definitely been a recognition that this is and children as well. I think there's been a push now to, again, historically people would take adult medications and just give them to kids, and kids react differently, and sometimes have different side effects or behavioral issues. So. And sometimes they don't even look the same. An example in the depression world, depression in kids often is a much more fluctuating kind of illness. They may seem better for a few days, and then they're depressed for a week or whatever, and better. And it's harder to differentiate that from normal behavior in terms of being a teenager or something like that.
Mm-hmm. It's funny, just to kind of digress from our show today, and then I'll get back there. I am absolutely chomping at the bit to get somebody on here who specializes in women, especially menopause and treatments and natural remedies. And I think we rush to, hysterectomies and bioidentical hormones are big now, but we've got to do more for middle-aged women who are going through menopause. And I know that's not your issue.
Right. But
it's frustrating.
Yeah.
I can't even find a specialist to come on the
right.
show.
And it's funny, but recognition, at least in the psychiatric world, is key to people helping themselves, whether it's in yourself or a loved one. And the numbers are stark. I mean, I would say, unlike in Parkinson's disease, where Michael J. Fox has really made a huge impact in terms of research and development of new treatments, we don't really have a spokesperson like that in psychiatry. And if you stop and think about, let's take depression, for example. If you look at the World Health Organization, they keep statistics about this. And they say that there are 350 million people right now that live with depression, and it's the leading cause of disability in the entire world. So it's more disabling than cardiovascular illness or malaria or some of these other cancer, things of this nature. And in terms of what you're talking about, it often starts at a young age, and women are actually more commonly affected than men. And for example, 1 of 2 mothers out of 10 have depression after childbirth. So this is a crippling illness that is not often recognized. It happens more often in women. Shockingly, 1 million people a year take their own lives. And
do you think depression is on the rise? Or do you think we're just more aware?
I think it's hard to tell. I think that it's largely a feature of stigma and recognition, but until we're better there, it's hard to know if, it's the same question when people talk about autism, of whether there's a rise due to various issues or whatever, or whether we're just now really able to see in a much younger child that there are issues taking place. But, I mean, if you think about just for a second, the suicide rate right now in the U.S. is in the 40-some-odd thousand people a year, and it was 40-some-odd thousand people a year 20 years ago. Car accidents where people died was, 50, 60,000 a year 20 years ago, and now it's 30,000. So we've, through technology and effort and community push, we've made a huge improvement in that area, and we've made no change really in the suicide rate. Recognizing depression, of course, suicide is fortunately not a common event in someone who is depressed. More commonly, people feel terrible and don't want to hurt themselves. But it's an area where we're not having a very good public discussion about psychiatric illness. There is a tremendous issue with stigma. I'll give you an example that we recently helped sponsor a fairly new organization called Mental Health in the African American Community. They had their second annual Mental Health Fair and Walk, and their goal is to really improve awareness and then subsequent treatment in the African American community.
Are the numbers higher in the African American community, or is this just a specifically targeted group? In a lot of cultures and races, there is less awareness. There's more stigma. There's less access. There's people wait longer to get treatment, which means it often is more difficult to treat or has caused a lot of other problems. I mean, it's like, if you wait long enough with diabetes, you have a neuropathy and eye problems and all of you. If you ignore it, it's much easier to treat and manage something earlier, and that's true across all of medicine. I mean, there are other organizations like NAMI, National Alliance of Mental Illness, which has for many years been pushing awareness, but it really needs a large groundswell to effectively move people forward. I mean, when Robin Williams committed suicide, there was a lot of press for about a week or two, and then that has really waned. There isn't a continued. There's so many questions I want to ask you, and we're going to get to the clinical research because I know you're with Carmen Research, and that is such an important topic. But, with the whole depression and my question earlier, I feel like, and this is the non-educated expert asking the educated expert, but I feel like the world is getting so much more, the United States is getting so much more sedentary in our routine and behaviors that my suspicion is that depression is skyrocketing because people aren't getting out there and exercising, and kids aren't getting out there and exercising and releasing the endorphins, and then they're living a lifestyle depressed and maybe don't even recognize that they're depressed. They just think that's normal.
Right. Well, depression is I think depression is a clinical state in which there are a lot of behaviors, for example, involved. So I think what you're getting at is very important. There is good evidence that exercise can help with one's mood, and in combination with treatments, for example, someone's depressed, can help speed up the benefit. But I don't want to minimize the fact that depression is just like a heart attack or cardiovascular illness or something like that. So unfortunately, depression was very poorly named. I mean, we see patients, for example, geriatric patients fairly commonly that will describe to you they don't feel depressed, but they meet all the other criteria. They have fatigue, they have lack of interest, and they have the biological state of depression.
Let's talk about that. What is the criteria? And I know I keep cutting you off. There's so much to get out here, but this is important. Depression is a clinical diagnosis. It's not a situational. It can be situational that leads to a clinical diagnosis. That's
the problem, is that if you say to someone, I'm depressed, they're going to be like, over what? And then they're going to be like, well, get over it. So it was very poorly named. It should have been like, it should have been, feel like manure syndrome should have been a better name, just because it's a total body.
That's awesome.
Total body experience and biological experience. People, and they have medical issues. People do poor, in a lot of areas. It's as I mentioned, it's the most disabling disorder in the world. So depression is a constellation of things that involve feeling depressed or having a total lack of interest in things around you, in activities or people you used to enjoy. And it's associated with things like sleep disruption, feeling sped up or slowed down, feeling that it's very difficult to concentrate or focus. For example, the term sometimes is used pseudo-dementia for people who are depressed. So a lot of times when someone is starting to have memory issues, this could be depression or it could be maybe early Alzheimer's or other issues like this. Could be, there could be other biological causes as well. People will feel that life is not worth living or more serious thoughts about death or dying or hurting themselves.
Or even just like it doesn't matter.
Right.
I
That's
think
common.
they get to a...
Right.
I can't
right.
think
I
of
want
a
to get
word.
away or feeling that life isn't worth living, that type of thing. Fatigue is very common in depression. Having trouble even making simple decisions is very common. Things feel overwhelming. So there's a lot of associated symptoms with depression. A lot of times appetite changes or interest in food. People will either eat too much or too little. So everybody's depression is a little different because some people will, eat more when they're depressed, or depending on, or it can vacillate back and forth, or they'll feel sped up, or they'll sleep too much, and other people will sleep too little, and that kind of thing. But it across the board is a very, it feels very different to the person. They are unable to function a lot of times. The sad thing is it can go on for years and be unrecognized, and even when people seek treatment, it can take a while for them to get better. I had a patient a number of years ago who I took probably 6 months of trying different treatment, and they were in like about their 7th or 8th month, and they were doing pretty well. And I said, "Wow, you really stuck in there." And this patient said to me, "That's because you told me that it was going to take a while and it was going to take 6 months." I hadn't even remembered saying, "Well, it could take 6 months or more," and they stuck it out because we don't really have a good genetic basis for which is the best treatment. There are some efforts and some potential studies coming where we're going to be looking at, and in a lot of the studies we do now, we do some genetics as part of the study.
And I think it's just... it's difficult because when you think depression, you immediately think meds, and a lot of people don't want to take those medications that are out there for depression.
Well, there's no question that therapy can be as effective as medication, and combining treatments. There's a number of studies that have shown combining medications and therapy, or combining medications, for example, and exercise. There's even some studies, interesting work going on into mirror neurons. So when you yawn, for example, I'm going to yawn, and there are some cells in your brain called mirror neurons that kind of look out in the world and will mirror what's going on. And, you can help activate those in different ways. One example is trying to really imagine yourself as you would be doing things not depressed, and then force yourself to do those things and be very formalistic about it. So in other words, if, say you've been depressed for 6 months, but normally this time of year you would go out with certain friends, or you'd be reading or knitting or gardening or whatever, and you're not going to want to do it. But if you force yourself to do it and you do that multiple times, that can help, kind of a feedback loop of help you start saying to your body, "This is what I do when I'm not depressed. These are the things that I've been avoiding to do when I'm not depressed." And there's some evidence that, kind of the fake it till you make it has some
I think that's
basis.
that book, The Secret. Isn't that what it is? Because it's kind of self-fulfilling prophecy principle.
Right. Well, there's even been some studies suggesting that you can keep a person from looking as depressed, like things like Botox or other things, that there is some feedback to having an antidepressant type effect. So that it is important to continue to try to push to do things that you would normally do. And that's true. I mean, that's true even of mental issues when someone has, for example, Alzheimer's or early Alzheimer's, continuing to push to continue in that, cognitive beneficial things that they would normally be doing.
Okay, so time always goes way too fast. But I do want to talk about if someone feels like they could be suffering from depression, or they know they are, but maybe they're influenced by listening to you today to do something about it. What would you recommend the first steps be that someone take to get help?
I mean, it really is recognition, and it can be as simple as talking to a friend or significant other, or a counselor, a pastor, seeking their primary care doctor's opinion. There's some good, a lot of the associations like NAMI, National Alliance for Mental Illness.
And I have that right here. There's a website folks can go to, www.nami.org, and I'm sure there's lots of great information.
Yeah.
That's the National Alliance for the Mentally Ill.
Right. And there's a lot of them. There's National Depression and Manic Depressive Association, and that's ndmda.org. There's NARSAD, National Alliance for Research on Schizophrenia and Depression, and that's NARSAD, NARSAD.org.
I think the important thing is there is a better way to enjoy quality of life. And
Yes.
if you're suffering with this, just like diabetes or insulin deficiency or any other disorder,
Right.
you can't do it alone. There's a much better way to live.
Right.
So let us help you. Who cares if you're going to
Right.
therapy? Who cares if you're taking some medications?
So we have been doing studies for new medication for 34 years, and I've been at Carmen Research since 2008. So, and Dr. Carmen obviously turned 70 this year. He's still there every day seeing folks and all. And so the difference between 34 years ago and now in terms of treatment is night and day. I mean, currently we're looking at things like depression and even geriatric depression. We have studies in Alzheimer's, ADHD, fibromyalgia. I mean, the issue is a lot of times as illnesses or in the age range, for example, ADHD, we're doing adult ADHD. 10 years ago, there really wasn't any treatment for adult ADHD. There wasn't a recognition that as people turned 19, they still had issues, and they were significant issues. It affected their work, it affected their schooling. So the thing is that if they seek help, that's the most important. Now, in terms of for us, if someone doesn't have significant other issues, unstable medical issues like seizure disorders or active cancer, and they have the illness that's being tested, and they can come and see us. We're in Smyrna on a fairly frequent basis. Well, one advantage is we follow people closely, and one disadvantage is they have to come like weekly or every other week or something of this nature. But I mean, the reasons to think about research if you're suffering from one of these conditions, or you think you might be, because we can do the assessment, is that newer meds certainly may offer faster onset, better response, and better tolerability, and that's what our goal is in developing newer treatments. There's no cost for people. There's often travel stipends included, so we don't want people to lose money to come and see us.
The important thing is don't try to keep going every day in a depressed state. Really, there's so much more to life out there for you. So
I would say in any kind of state. Of those I mentioned, depression is in the top 10, is in the number one most disabling disorder. But out of the top 10, 5 of them are psychiatric conditions, things like PTSD and bipolar disorder, schizophrenia. So I would say if someone is not having good, is having issues psychologically, then they need to get assessed.
And please go to some of those websites that Dr. Shapiro was so good and kind to give us.
And they can certainly come to our website, carmenresearch.com. We have links and information and that type of thing.
Perfect. We have to take a quick break, but don't go away because there's so much more to talk about. And when we come back, we're going to give you lots more information about how you can get help right here in the Atlanta area. Hello, I'm Jean Pete, and I welcome you back to our show, Better Living. Better Living is brought to you by the Homestead Hope Foundation and is sponsored by Homestead Hospice, where commitment to education and premier hospice care helps patients and families through life's most important journey. Thanks for staying with us today. I'm still here with Dr. Shapira from Carmen Research in Smyrna, and there's so much more to talk about. During the break, we were talking about the difference between someone who gets depressed early on in life and how that manifests later in life. So I want you to touch on that now that we're back on the air, because that's important.
Well, clinical depression is usually a relapsing, remitting illness. So people will go through having episodes of depression. Now, those can be different length. Technically, in terms of diagnosis, it has to be at least 2 weeks long. Often it could be months or years, but there can be a break that can go on for, technically it has to be at least 2 months to be considered a new episode, but it can be obviously and hopefully much longer. The issue is that when someone is young, statistically, they're more likely to become depressed due to a stressor. And I think we intuitively know this. I mean, we see people in college or young life that there's a stress going on, and they have they lose a job or whatever. Actually, depression probably over time changes the biology in the brain, the periods of depression, and usually when someone's in their 40s or 50s or 60s, depression doesn't necessarily come on due to a stressor. It just, the person all of a sudden starts feeling bad and having all those physical symptoms they used to have and that type of thing. So,
and let's talk again about those physical symptoms, just to remind folks: lack of interest in activities and people that they used to enjoy being with.
Right.
Sleep disruption. You might be sleeping much more or much less.
Yeah.
Feeling slowed down. Just it's tough to get going.
Or
tough
sped
to
up.
focus,
Actually,
or
people can get very irritable and agitated.
I've seen that. Actually, that's happened to me before.
Yeah. That's happened.
Memory issues, fatigue, or feeling sped up, motors running. Making simple decisions gets more difficult. Your appetite has changed. And
I see a lot of people who have the coulda, shoulda, wouldas. They a lot of guilt. They start ruminating. So like a cow might chew on its cud, it's over and over and over. And sometimes people will say at night they think over and over. They can't sleep. They think they did something wrong, or they should have done this, or they could have done this, or they're a bad person, or these kinds of. These are very common in depression as well.
So let's talk about this, and we have so much more to talk about. I think we might need to bring you back just to talk about Alzheimer's and depression in the elderly, because we're not going to have enough time. But this is so important. We all know folks that have had an episode happen to them, a death of a loved one,
right?
A car accident where they're disabled versus what they used to be, whatever the case may be, an illness in the family, a loss somehow. How do you know when it's now something that clinically they need to get help with versus, come on, let's pull you out of this and go? As an observer, it's so difficult to watch.
Right. Well, we try not to pathologize everything, to make everything into a disorder. It is normal to have a period of bereavement, for example. It is normal for people to have certain behaviors. The issue is when it becomes crippling or disabling. Just a simple example might be, if I write you a script for a medication and I check it once or twice, that's actually good medicine. If I'm checking it so much I can't give it to you, I have a problem, right? Because I'm not functioning in my role. I'm not able to perform, my job. And you see this depression is similar. It's how deep it is, how long it's going on. Is it causing inefficiency? A lot of times we'll ask people, well, how much less proficient are you at your work, at home? A lot of times people don't even get out of bed. They need motivation, or they get very slow to shower and bathe,
or like you mentioned, those thoughts go at night, so no one can go to sleep. So then they can't wake up, and they're late for work every day, and then they start getting in trouble.
So it's really a level of disability, and unfortunately, there's not a specific. In a lot of medicine, there's a size of a lesion or an exact number of the blood pressure or sugar levels or all these types of things. Unfortunately, it is still more subjective, and there's a clinical impression. But I think a lot of people have a pretty good sense of when something is really either very disturbing or disabling.
And so let's walk through what are the first steps you would take if someone was influenced enough to seek help and arrive at an office to get help. Let's take some of the fear and stigma away, and can we try to walk someone through maybe the first, second, third meeting, what we can do to help people? It's really not that big of a deal.
Right. I mean, I have to encourage people to really, take their time and share what they've been going through. I mean, there are some realities that are unfortunate in our current medical system. And one of them is the time element in visiting like a physician. I mean, we have, in a research setting, we make an appointment and we have that time that we set with them, which could be an hour or 2 or 3 or whatever we feel it will take to sit with them and go over what's been going on. I think, when I go to see a physician and I look around the waiting room and I'm thinking, how come 10 other people have my appointment time? I don't get it.
That's true.
I don't really get it. So I think what you can do if you're seeing your primary care doctor or you're seeing a psychiatrist, I think come as prepared as you can be. I mean, that helps really.
Maybe write stuff down.
Write stuff down. Having,
it
really
might be hard to talk the first time.
Yes, talk to others that know you. Get a real sense. It's almost more diagnostic. There's been studies that have looked at the look of someone who is depressed. That you're almost more accurate seeing someone across the room who looks depressed than asking them how they feel. Sometimes in depression, people have the inability to be in touch with their own emotions. For example, when someone starts losing interest in things or in people, the severe part of that is they lose. Often they feel numb. They lose the inability to actually be in touch with their own emotions. So certainly, if you're seeing a physician or therapist, try to be as prepared and be open to discussing. The person isn't judging you. You're in a safe environment to talk about what's been going on and some of your frustrations and things like that. So this is what I would say. I mean, try to not say it. Sometimes we've joked about the doorknob comments. So, you've gone through the meeting, you've talked about, let's say, your primary care, you've talked about the 8 other things, and then the very last thing is the doctor or nurse or whatever is getting to leave. It says, oh, and I've been feeling depressed. It doesn't. Depression is incredibly important. It probably is one of the reasons your blood pressure is not as well controlled, whether it's due to depression itself or you're not taking your medicine as regularly as you need to or whatever. It is actually critical.
In physical illnesses. So you really think I'm very sick, but it's got to come out of your body somehow. Right.
There's definitely more somatization. People who are in pain feel pain more strongly when they're depressed than when they're not depressed, even though the pain hasn't changed. People who've had heart attacks, if you're depressed after a heart attack, you're more likely to actually die or have another heart attack. So there's a versus people who are treated from their depression. So it's with the same heart attack. So there is a biological change that takes place when people are depressed. Maybe people clot more, things of this. So there are changes that are important. So don't make it the last thing you talk to your doctor about, I would say, because, you have a limited amount of time or whoever you're going to see. So these are some of the things that when someone is going in to see someone, be prepared and talk about it first. Okay,
so you go in the first time. Try to be prepared. Write down on a piece of paper the things you want to talk about. Because once you get there, you're going to be nervous. It's a very uncomfortable situation, I'm assuming. And the more that you do to prepare for that first meeting, the more you're going to get through, first of all, in that first meeting. And the closer you're going to get to getting to work on it.
I think a lot of people will express to me they feel like failures if they have to take a medication. And I think it's a feature somewhat of being depressed. Depression is sort of like everything bad sticks to the person and everything good, and there may still be good things going on that they can't really process. But that, I hear that pretty commonly, and that is a difficult thing to get through. In other words, there are side effects and issues with medications and whatnot, and those aren't, you can't minimize that. But at the same time, Prozac, for example, came out in the 80s. Zoloft in the 80s, early 90s. I mean, these medicines have been out now, many of them for 30, 40 years. So there's not really a bad, a person's not going to grow a second head taking, an antidepressant or something like that. There are side effects and risk and benefits to everything. But I would argue that there are as many or more with things that people might buy over the counter, like some of these herbal products that somehow people feel are safer and more effective. But the data, there was a recent in New York, I'm sure people have heard that they did a study and went in and to major stores, Walmart and Target and whatever, and bought the various herbal products. And I think it was 4 out of 5 of the bottles didn't have in it what's said on the label. Now, you're not going to get that in a regulated industry, which we are very carefully regulated, and the manufacturing is very carefully regulated. When it says whatever on the bottle, it actually is going to be that antidepressant or anti-anxiety or that type of thing. And the other thing is a lot of these things that are over the counter actually do have significant drug-drug interactions and do have significant negative effects, but we kind of talk about them as, then the bar is not as high for testing for a lot of these herbal type of products. So that sense, I see patients all the time. I don't want to take a medicine, but they're taking 10 herbal products. It just doesn't equate in a sense, and it's not actually helping them. Right. I mean, there is some evidence. There are some products and herbal type things that have shown some, evidence in various things, but by and large, they haven't.
And I don't know if they're as regulated. They're not as regulated.
They're
so even the way they're manufactured, even if they have the right medicinal benefits, right. you could be...
I think there's a movement, and hopefully it will take hold where there is better self-regulation and testing by some of these large companies. And there are some countries, I think Germany, for example, does more significant testing of what's in the herbal products. But by and large, it's kind of like the Old West. It's like a couple hundred years ago when a buggy would pull up and, and they're giving you a bottle and you don't know what's in the potion. You don't know what's in the potion. And so this is an area which needs improvement.
So let's talk about the I keep saying the word drugs, but the medicines that are available for depression these days. You mentioned Prozac, you mentioned Zoloft. I have to tell you, as soon as that comes out of your mouth, I get a little anxious because you hear about some of the side effects of the Prozac and the Zoloft. Are there newer medicines?
Yeah, I mean, there's we've been involved in almost all of the antidepressants from Prozac on. There's probably about 15 now approved on the market. We were involved in the last 3 or 4 that got approved.
Is there a new promising med that has less side effects out there?
I think there's always a balance between side effects and benefit. And this is why my hope for the future would be we would be able to do some testing. Right now, the reality is a lot of times you're kind of throwing a dart. You're not sure how the biology might be. I've had people who have almost, no side effects on some of these antidepressants and have a brilliant effect. And so other people have, a lot of nausea or whatever, or agitation or whatever. So it really is a feature of staying in touch with your doctor, getting back in touch, trying a different thing. If that doesn't work, there are enough choices now, I think. I'd say, in the 90s, we have, 3, 4 choices, and some of the older agents, which have significantly more side effects. There are a lot of choices now, and there's even medicines to help those antidepressants work better in people that have taken them, and we were involved in some of those approvals as well. So the issue is really not pushing forward and trying things or really being in contact with your doctor about that. I mean, our goal, the reality is if you take 100 people and give them just an antidepressant, about 25 of those people will have a huge response. They'll, be 90% better. They'll come in and say to me, Dr. Shapira, don't touch anything. You know what I mean? That's really,
working.
that's it. That's the person. That's when you put a big smile on your face. And that's not a small number of people. About 50% of those people will have some effect. It will be beneficial, maybe 40% better or 50%. So they're not having those huge low days, but they're not better. It's different than, we talked about antibiotics before. It's not like, okay, the infection's gone, right? Mm-hmm. And then about 25% of people think you gave them water, like nothing from it, or the side effects were just not to the point. So, I mean, we're putting a lot of effort. I'd say we've done about 400 studies over the last 34 years, and about half of those have been in depression. So that gets a sense of how important the area is and how much effort we're moving to try to get better treatments or augmentations or things like that.
So let's talk about that. You do clinical trials. You had mentioned earlier in the show about no cost, and sometimes you pay for transportation.
Right.
Let's talk about folks that might be listening today, and they think, well, I can't afford therapy. I can't afford to go see a psychiatrist. Talk about what Carmen Research does, what some clinical trials are right now, and if somebody were wanting to get involved, what that would entail and how they could get involved.
Right. So we're doing a number of studies in depression, including geriatric depression. We're doing several studies in Alzheimer's. And the reality is Alzheimer's has different stages. For example, very early, like mild cognitive impairment, or early Alzheimer's, where people might have some awareness and still have some functioning. And the goals in that kind of area is to slow down or the onset or prevent kind of the progression. And then later on, there's a lot of issues around agitation and cognition that as people get into middle Alzheimer's that we're trying to have some benefit in. Because really, we talk about not only the person with Alzheimer's, but then there's all the caregivers and caregiver stress and the
depression of the
caregivers. Sure. And these are very and having the ability to really work with their loved ones or clients or whatever is critical. We're doing studies in adult ADHD, fibromyalgia, which is actually a very becoming much more recognized and often very crippling area. We've done a lot of studies in anxiety disorders, bipolar disorder, insomnia, pain, things of this nature. The issue is that it's not uncommon for us when the nice thing about a study is there's often a very significant workup. We'll do EKGs. They're often read by cardiologists. We'll do very complete blood work, probably more workup than most people will ever get seeing their primary care doctor. With Alzheimer's, there's a lot of imaging that's part of that, and that's all part of the study and all. So these areas
it's paid for,
and they don't have it's at no cost to the person, and it's not uncommon. I had a patient last week or a subject last week who screened for a study, fairly young female. It turned out her thyroid wasn't working right, and we could see it, and we were able to inform her of this. And this is probably a big cause of her depression, is that she has thyroid dysfunction. So we look for a lot of things. Anemia is pretty common that we find, and we're able to alert people to things like that, vitamin B12 deficiency, things of this nature. A lot of times people will participate in research not only to potentially help themselves, but also, they're like, for example, depression is a recurrent illness, and I've had a number of patients that wanted me to tell them when the compound that they were part of a study actually was approved because it was the best thing that worked for them, or they really tolerated it and they wanted to know, And sometimes it's a couple years later, that kind of thing. We're able to say, okay, now it's on the market, and you can, or for their children, a lot of disorders have some genetic basis, and if you will, they want to try to give of themselves to see if something new can be developed. The other thing that's interesting about research is that it's a lot of money for a company to develop a new medication, but it's a drop in the bucket, it turns out, for what savings there are to the society. So it might be $800 to $1 billion to actually develop a new medication, which is a huge amount of money, right? But the savings, one small example, there are a lot of examples of this, but there was a study done in 2000 that if you could drop the rate of cancer deaths by 1%, you would save, the savings is $500 billion. So a small change, because these are very large illnesses with very large effects on people in their lives, on their productivity, on death, things of that nature. So one thing, at Carmen Research, we have a 24/7 call coverage. I think we want to talk to people who are in studies. you call a lot of places and they'll be like, if this is an emergency, dial 911. Well, I mean, if the person breaks a leg, we want them to dial 911. But if they have an issue of what's going on, and we want to monitor them closely, we want to talk to them, right? And
so can someone just call you and come in and apply?
Sure.
To be in one of these clinical research
studies? Yeah, they can go to our
studies?
website, Carman Research, CARMAN Research, oneword.com, or they can call us.
And then once they're accepted in,
right.
How often do they come and see you? Or is
it depends.
Different
Some
study?
studies, right? Some studies will go on for years. Some of our, like Alzheimer's studies, because they, you want to see if we can slow the progression. Some studies have a extension study where even if they may not have gotten the compound in the, say, 8-week or 10-week or 12-week study, because it's a blinded study, they can receive it in the year-long extension, see if it really works for them.
Okay,
that kind of thing.
This is a bit of an issue. If they are in a study
right.
and they have a positive response, when the study's over, they can't get the med that they know has helped
right.
them. Oh, that's frustrating.
Right. Well, so we always offer like 3 to 6 months of follow-up care at no cost. We want to appreciate people who've participated in studies and really helped move things along. Some studies we do are actually with medications. I would say about a third of the studies we do are with medications that are on the market.
Okay.
They're trying it in different ways, or the FDA wants additional data. The other third are medications that are hopefully potentially going to be on market, or if they don't work, maybe it would be an area where, it wouldn't be something that necessarily, long-term might be beneficial to them. We always try to find something similar or try to establish with them afterwards, that benefit that they had. I'd say more and more studies are offering these year-long extensions where people, if they're doing well or maybe even not, they get to try the compound. And a lot of our studies, I would say a number of our studies have actually in the last few years been open label. So we did a bipolar study, which everyone was receiving. We did an ADHD study where everyone was receiving the compound being tested. So the goal was more of a tolerability and did the person like it long-term, but it wasn't you're not going to keep getting it, or you don't know if you're getting it during the study. The other interesting thing that has changed over the years is most studies about 8 years ago were you either got a drug or placebo, like if you were developing a new antidepressant. And every study we have now is everyone is given best standard of care, like in depression or whatever, and that the medicine being tested is being added to that to see if it makes it work better. So we are actually trying to get everyone better in a lot of studies that we're doing with standard of care. And so we've moved more into the world, I would say, where the rest of medicine is, where there are accepted, solid treatments, and the studies are looking to give everyone a base treatment and then add to that.
Okay. So one more time, can you give, because we're running out of time again, and you have to promise me you'll come back, because we didn't even touch the tip of the iceberg. If someone wants to contact you about a clinical study you're doing, you mentioned ADHD,
depression,
Alzheimer's, fibromyalgia. Those are 4 of the biggies right now.
Recently, we're involved in a bipolar study, things of this nature.
Bipolar, that's important too. I think there's a lot of people are undiagnosed walking around with bipolar.
Sure.
How do they get in touch with you? Phone number, and again, where your address is.
Sure.
Location.
Well, again, www.carman, research.com, or our number is 770-333-0093. 770-333-0093. We're in Smyrna, and we're right on the Ridgeview campus. We're in the outpatient building for Ridgeview.
And just remember, you don't have to live with a lack of interest in doing things or a lack of interest in being around people. If you're not sleeping, if you're not eating according to your typical routine, if you're just feeling slowed down or revved up, please. This show is called Better Living. I do this, and I'm blessed to do this so that I can help you all live better. And if even just one person talks to Dr. Shapiro and the Carman Research team, then I'm blessed to do the job I've done today as well. So thank you so much, Dr. Shapiro, for being here. And we're going to bring him back, and we're going to talk specifically about Alzheimer's and some of the other diseases you mentioned, Huntington's disease, and we can talk about bipolar as well, because there's way too much to talk about here in one show. I'm Jeannie Pete. Thanks for listening. Have a blessed day and week ahead, and listen here same time next week and every week. Homestead Hope Foundation is your resource for a healthy life. God bless.